rounds for the University of Colorado Anschutz Medical Center. Our presentation today is ethical issues in the medical response to elder mistreatment. I am Julie Swaney, moderating the session today, and if you would please put your comments or your questions in the chat, I'll read those to the group for Dr. Bloemen to address after her talk. And before I introduce her, I do want to mention that our next ethics grand rounds will be March 14th, and we will be addressing psychiatric patients and decision making. So again, I am really honored to introduce our speaker for today. Dr. Elizabeth Bloemen is an assistant professor of geriatrics and the medical director of the Vulnerable Elder Services Protection and Advocacy Team, VESPA, at University of Colorado. And as an elder abuse researcher, she's committed to improving the identification of and care for older adults who are experiencing mistreatment. She's a graduate of Columbia University Mailman School of Public Health, where she received her MPH with a certificate in aging, and she completed her medical school at University of Colorado Medical School in an internal medicine residency and geriatrics fellowship here at CU Anschutz. So I'm going to turn this over to Dr. Bloemen. Thank you very much, and looking forward to your talk.
Thank you so much for having me. I'm going to, hopefully this works. Can everyone see my slides?
Yes.
Okay, perfect. So yes, everyone, thank you for having me. And today we will talk about a little bit about elder abuse. So I have, let me see if my slides up. Yeah, there we go. No relevant financial disclosures, although part of my time is supported through a Victim of Crime Act grant that is currently the funding for the VESPA team, although anything that I am talking about is my opinions alone and doesn't reflect the Department of Justice or VESPA. So today I thought we would go over a little bit about elder abuse, the prevalence of this important problem and the impact it has on our patients and families, understand the role of medical providers and medical systems in the response to elder abuse, and then we'll go through the kind of key ethical issues that we see every day in our hospital settings. So this will be kind of a bigger level overview, but I'm hoping we'll start the conversation to have deeper research and deeper conversations about the things that we are seeing every day on our team. So I always like to start with the definition of elder abuse, because when you start to get into it, it is a little bit of a nebulous concept. So elder abuse is, as defined by the CDC, which was actually the last agency to develop a definition. So this came out, I believe, in 2015. But everyone in the field kind of likes this one. This is what we've settled on. But elder abuse being an intentional act or failure to act by a caregiver or another person in a relationship involving an expectation of trust. And that expectation of trust is really the key here. And that can either cause harm or create a risk of harm for an older adult. And so this is what we use to distinguish, is this elder abuse and that phenomenon, or is this just kind of bad things that happen to older adults, or even being targeted because of age or targeted because of other identities? That's separate to the core phenomenon of elder abuse. And so that relationship that involves the expectation of trust can be really varied. So typically it could be a familial relationship, a spouse, a romantic partner, an adult child, adult grandchild, a neighbor, if they're part of your social circle and you have a trusting relationship with them. Can also include paid caregivers, paid home health aides, paid nursing home workers. So it can be really varied in terms of who is that person, which is why we like this definition. It's really inclusive of the spectrum of the phenomenon that we see. And there are 5 core types of elder abuse that we see every day. And these are very similar to other types of violence that we see across the lifetime. So we see a fair amount of physical abuse. That one's relatively straightforward. We do see a lot of psychological abuse and verbal abuse, including isolating behaviors, coercion, control, particularly cutting other family members out of a social situation, threatening patients, those types of things. Sexual violence, unfortunately, does persist into later life. I think this is the one that makes people the most uncomfortable and has the most misinformation around it. As we all know, sexual violence is not about sex or sexuality. It's about power and control, and we do see sexual violence in later life as well as we do in earlier life, but it is grossly underrepresented in both the elder abuse field and the sexual violence field. Older adults have really been excluded from this. And it's a particular passion area of mine to make sure that those victims get the care they deserve. We also see financial abuse, and financial abuse, I think, is more common in elder abuse than other types of violence across the life course. Certainly in child abuse, a lot of kids don't typically have a lot of money to abuse them with, thankfully, but in domestic violence, we do see this. In intimate partner violence, we see this, but in elder abuse, this is really core to a lot of the cases that we see, is that people are trying to get financial resources from the older adult, whether that be getting money from them or living in their house without contributing, taking their car, taking other possessions, taking some sort of financial support from them in an abusive way. And we see this as often one of like the earliest pieces of elder abuse, and then it escalates into other types. And then neglect can be really tricky as well. And I'd say typically how I think about neglect is a little bit on a spectrum. And so we see neglect early on, and we can see what we see in clinic every day, where we're like, things aren't going great, but it's not really meeting the level where I'm super concerned. Maybe we're missing a few doses here and there. Maybe we're missing a few appointments here and there, but overall, we're really doing okay, up to seeing people in the intensive care unit. I think the highest sodium we've seen is 177. So that person has clearly not been fed or provided with water for many, many days, if not weeks. And so we see neglect kind of in the bimodal distribution, but neglect is what I consider the terminal phase of elder abuse. So when we see cases that are reaching fatality, it's usually from neglect, less from physical abuse, which is different than the violence of younger adults. And as is typical with other forms of family violence, we often just don't find one subtype of abuse. We see multiple abuse forms occurring at the same time or evolving over time. So usually we're seeing polyvictimization, not just one abuse. The elder abuse is a lot more common than I think most people think it is. We know from pretty good community studies done in multiple states that about 10% of community dwelling older adults experience elder abuse each year. Notably, these were all done a while ago. So they were done with landlines. And so it was a telephone survey. So you had to have the cognitive capability of answering the phone and not have the abuser standing right there to answer this. So this is likely somewhat of an underestimate, but we think about 10% of older adults experience some form of mistreatment each year. That number goes up to 20% when we're looking at long-term care. And that can also include resident to resident abuse, which is a really different phenomenon and kind of a different kettle of fish, but does happen. It also can include familial abuse that's happening in the long-term care setting. And so it doesn't necessarily have to be from staff in that situation. And as I've alluded to before, this is at its core family violence. So I think the cases that get in the media and get the most attention are the home health aides, the nursing homes, but really most of the cases, a family member is our perpetrator. And so we treat this phenomenon really as a family violence phenomenon. And in Colorado, I'm looking for the more recent APS numbers, but this is what I have so far. APS gets about 24,000 reports. They substantiate about 8,000 reports. APS cannot investigate if a patient has capacity and they don't want them involved in their life. So they are very limited in what they can do. They have very strict vulnerability criteria. So I think the real number is probably somewhere in the middle between these two, between the reports and the substantiation. But this is happening all the time and is a big problem in our community. And very concerningly to us, those of us who study this and who work in this field, we know that for every one case of elder abuse that gets reported to anybody, there's about 24 others that are not reported or identified. So we have a lot of people who are not getting the care and services that they need to live with dignity as they age. And we know elder abuse has really dramatic impacts on families and patients. So there's a 3 times increased risk of death in the year following mistreatment. This actually includes most mistreatment types, even financial, which I think people can think of as more benign than a physical violence episode, but that still does increase your mortality risk. There's also a substantial risk of nursing home placement. This is often multifactorial. Partly there's a perception that going to a nursing home makes people safer. I don't know if that's necessarily true based on the data we just saw, but certainly gets them away from one abuser. And also because often financial resources that could potentially have paid for home care, paid for alternative placement, have been depleted as part of the victimization. And so we see a lot of nursing home placement. This, I think, is particularly burdensome for our vulnerable populations and our patients who don't speak English or who are immigrants, patients who come from rural areas who need to leave their community because there isn't a care option available for them there, our LGBT patients who often go back in the closet when they are placed in a nursing facility. So I think about this as typically a bad outcome for any older adult. Every day in my clinic at Seniors Clinic, patients say, I just don't want to go to a nursing home. But I think about for my patients where going to a nursing home is particularly devastating, that this outcome is something we really want to try to avoid. And then there's certainly a huge risk to mental and physical comorbidities, both causing them through injuries, through neglect, but also exacerbating them. What I tell my residents is if you think about the social determinants of health, abuse can impact every single one. It affects your access to transportation, to medical care, to food, to nutrition, to your financial security. So if you're thinking about this, I like to think about this as the ultimate social determinant of health. And so can have very large impacts on our patients and their outcomes. And so why am I talking about this and not one of my lovely social work colleagues? And I think this is something that we have, I think, changed the needle on at university. But traditionally, elder abuse has been seen as like a social problem, justice problem, not a medical problem. But to me, this is core to medical care. This quote is etched outside of building 500, which I think we're now calling the Fitzsimmons building. But this really struck me one morning when I was walking around campus, because I do think that there is no greater disease that causes sorrow, need, and sickness than being abused. And so I think this is something that really deserves the attention of physicians, of medical providers. This to me is a core medical problem and a public health problem, and one that needs our care. And so we are hopefully changing the culture around this. And we have some good evidence that that started to happen here. And I think part of why we have such a receptive community to this is because of this man. For those of you who don't know, this is Dr. Henry Kemp, who ostensibly started the field of child abuse here at the University of Colorado. And what Dr. Kemp so wisely knew is that if we want doctors to pay attention to these types of things, we need to give them tools to do so. Doctors are well-meaning, but we don't necessarily want to ask questions if we don't have a good answer or a good solution. And so what Dr. Kemp did was develop the first child protection team here. And so that team provides specialized services and took the burden off of the primary medical team to think about child abuse and neglect. And so that is the Kemp Center. I think we have members of the Kemp Center on, so I hope I'm representing your guys' work appropriately. But the Kemp Center has been a long-standing center here at the University of Colorado and has been a model for teams across the country. And so many years ago now, I was working at Weill Cornell before medical school, and I was working with Tony Rosen, who's my main mentor, and we were sitting around talking, and we said, you know, it'd be really great to have a Kemp for older adults. And so while I was here at medical school, Tony started that. So they started the Vulnerable Elder Protection Team, or VEPT, out of their emergency room. And they see cases of elder abuse and neglect, or anytime there's concern for that, and they provide a specialty consultation. They are available 24/7. They pick up the phone. They, hey, what should I think about? They'll recommend imaging, other things. They have kind of a more one consult model where they kind of see give recs one time, don't necessarily have as much longitudinal, but they are kind of our sister teams. We work very closely with them, and they started in 2017. And then our team started, we're called VESPA, objectively a better acronym than VEPT. We are having a competition to see which acronym will spread. But we started VESPA back in January of 2021, about 6 weeks after this little gal was born. This is my daughter, Genevieve. So both of my children were born around the same time, both VESPA and my daughter. And we have 2 arms, one at university and one at Denver Health. Our teams are made up of geriatricians, nurse practitioners with geriatric training. We work very closely with our forensic nurses. We have a dedicated social worker here at the university side, Sarah Cox, who is really the magic behind our team. And then we will pull in experts as needed. We have emergency medicine faculty on our team, and then we are mentored by the Kemp team as well to start this. And our 2 teams provide a very thorough history and medical exam. At university, we only see people in the emergency room and in the inpatient setting. At Denver Health, they're more of an outpatient model. But both of us give basically a geriatrics consult on steroids. We spend a lot of time getting collateral information. So the lovely Sarah Cox will often call every family member in the system to say, hey, what's been going on? Where are we? How do we help you guys? We often are doing the reporting to APS employees under the mandatory reporting laws. And then we also work with them to work through the medical system, but also help the patients and families navigate this and understand who are all the players, what do they do, and how do we really keep what the patient and family wants at the center of any interventions that are being done. We do a lot of safety, or what we prefer to call harm reduction planning, trying to figure out how do we bolster this family system. And then our team has a very strong emphasis on connecting back to the primary care medical home. Older adults in general who are in the hospital have a lot of transitions of care, often going from ED to ICU to the floor team to subacute rehab to back home, and a lot of this can get lost. So we often will directly reach out to the primary care provider and say, this is what's been going on. This is the APS caseworker, there's their phone number. Let us know how we can help you navigate this system, because we really want to make sure this doesn't get lost in all of those transitions. And then any case where we have a moderate or high concern for abuse, we offer something called a staffing to our community partners. And this is based off of the Kemp team. It's a little bit of a variation of the multidisciplinary teams that are done for elder abuse across the country. Basically, we get our entire VESPA team together, including all of our providers. We invite APS and law enforcement to join that meeting, and we go through the medical facts of the case and share our level of concern, why we reached that. We will only share information that we would normally share as part of reporting, but it allows us to go a little bit deeper and give context and explanation. And it allows APS and law enforcement to ask us a lot of questions and allows us to learn from each other. So we can really say, like, they have this kind of dementia. Have you seen someone with Lewy body dementia before? Let's talk about what that means, what their care needs are, that sort of thing. It also helps us say, hey, APS, they really need this follow-up appointment. Can you help us make sure they get to that? Or can you help make sure that home care is actually coming into the home? So it helps with that kind of coordination that we can often not do as just inpatient providers. At times, we've also been able to do staffing while the patient is still in the hospital, and that has sometimes been really beneficial if APS has gone to the home and they can tell us what the home environment looks like. That provides a lot more information so we can provide better care to the patient. So this is really core to our model and has had good feedback. And so our theoretical basis for approaching these cases is really a family systems approach and a risk and resiliency approach. So we think about older adults as entering later life with a baseline risk for abuse. Some people are going to be at very low risk, some people are going to be at very high risk, just depends on their life circumstances and known risk factors in the field. And then as we age, things happen that make us more vulnerable to being abused. So those things can be internal, like having a stroke, which is functional impairment, developing cognitive impairment, or they can be in your family system, losing a supportive loved one through illness or death, or due to financial circumstances, losing social connection. in general can be a huge issue for our older adults. But then there's also things we can do to build up resiliency and buffer people out of that abuse factor. And that is not just for the older adult, but also, again, for their whole family system. How do we help this family do things better? And so we think through this a lot in our team is, what put them at risk? What can we do to buff up their resiliency? And then was there an inciting event? Was there an argument over something? And was there something that we could say, we're going to target this piece for harm reduction? And try to figure that out. So, if the victim was trying to leave, or if there was an argument over finances, or the victim was trying to intervene in other types of family violence, we see that not infrequently, then how do we work on intervening on those particular cases to reduce risk in the future? This is kind of our theoretical model of how we approach our cases. So VESPA has now been around for 3 years. So this is my daughter now. And as I mentioned earlier, I think not very many people were on. I have now a second child. That's Arthur. We have now seen 471 consults, 362 at the U and 100 at Denver Health. Our case numbers have gone up dramatically. So since we started back in January of 2021, we went from 3 cases to just in January, this quarter, we saw 32 cases just in January alone at Just University. So our numbers are increasing dramatically quarter over quarter, which we think is a great sign that people are identifying this issue. We primarily see people over the age of 70, but we will see anyone 40 to 70 who's vulnerable. So if they have an intellectual or developmental delay or have early onset dementia, we will see them. And so we do see some people under the age of 60, but not very many. Most of our patients are female, although this number is actually pretty good for any aging population, and also pretty good for considering violence typically affects women more than men. We do see a fair amount of veterans, I think because we're the closest ambulance stop right next door to the VA. And we see a fair amount of non-English speaking patients, mostly Spanish, but we also see a lot of Amharic, Korean, and other languages with our immigrant community. Our racial mix is down here in this table. We are working on pulling our mix every quarter to try to make sure that we are serving all of the patients in our community equally. But we are continuing to work on that process. We see a fair amount of immigrants and refugees, and thankfully, so far, none of, we are tracking this, but none of them, their immigrant status has been used as the abuse. We did see that in New York where I worked previously. And about half of our patients have some form of cognitive impairment or a diagnosis of that prior to us being. So that is a big chunk of patients. We do know that functional impairment and cognitive impairment is one of the biggest risk factors for elder abuse, so it's not surprising, but it does impact our work on a daily basis and how we approach our work. And most of our patients are community dwelling, so about 70% live in the community. We screen for everyone else in the home and ask specifically about co-occurring family violence. And so this is slightly updated. We just had a case yesterday where there was co-occurring child abuse as well. So we're up to 8 cases of child abuse. We always make a CPS report if we have concerns about children in the home. In 2 of our cases, it was severe enough that children were removed from the home. We also ask about intimate partner violence of younger people and animal abuse, because that can also be used as part of the abuse and manipulation. We report to APS if we have any concern, if we have moderate or high concern for any type of abuse or neglect or for self-neglect. So in about 65% of our cases, we're making reports. We make mandatory reports to law enforcement when we're concerned about abuse or neglect. So we don't report to law enforcement if it's just self-neglect, which is why there's a discrepancy in those 2 numbers. But about 60% of the time when we're consulted, we say, yeah, we have concerns. About 35% of our patients have injuries or visible injuries, and about 20% meet the criteria for serious bodily injury, which is a legal criteria that differentiates a misdemeanor from a felony in the state of Colorado. Serious bodily injury is anything that could be permanently disfiguring, impact the function of an organ permanently, or threat to life, or a knife or a gunshot wound. So there's different definitions for serious bodily injury, but these are very severe cases. So these are the ones that are life-threatening most of the time. After we staff our patients, we give them a final kind of score, for lack of a better word, of where we are in terms of our abuse concerns. So as you can see, neglect is what we are usually the most concerned about, but we also see a fair amount of physical abuse and verbal abuse. We see sexual abuse. That number looks small, but that's actually the most cases in one center in the country. And when I tell other elder abuse researchers about this, they're like, "Oh my goodness, we didn't think that you would get nearly that number of cases." For example, at Cornell, they've been around since 2017. They've only had 3 cases of sexual abuse, and we have seen 2 in the last month. So I think this is because we're asking the right questions and giving this. So far, VESPA seems to be working. I'm working on a more formal analysis, but we get feedback from medical providers, and this was from one of our trainee providers. But I think it speaks to the culture change that we are trying to achieve as part of the VESPA team, and asking providers to say, hey, this is a medical problem. This is something you can do something about, to try to get rid of that nihilism that comes when we see things like abuse in our medical practice, where we just don't know where to start. And so VESPA, I think, is making that impact for medical providers. We're also having a good impact on APS and police. This is from one of our APS workers saying that it was one of the best experiences they've had, because it really helped them make a support plan for the client and improve the collaboration for that patient. And so we hear this all the time, not just from APS, but also from law enforcement, that it helps them help the patients more. And we've allowed law enforcement to help with orders of protection. We've helped APS make plans that are much more patient-centered. We really advocate for what does the patient and family want. How do we utilize the medical system in ways that APS and the law enforcement can't? Like, I can order home care, I can order DME, I can do a lot of things that they didn't have access to before. And so this collaboration has really improved the care that our patients receive, but also I think job satisfaction and worked on moral distress for the workers that work in this field every day. So now I'm going to transition over to the ethical issues that we see every day on the VESPA team. So we're going to go really broad strokes, and then hopefully we'll have time for questions and discussion at the end. So the first big ethical thing that we think about every single day is maintaining our role as providers. So we are really diligent about not becoming investigators on the VESPA team. So we want to make sure that we are maintaining that patient provider role as much as possible. So like I said, we do collaborate with APS and law enforcement, but we share that information as minimally as possible. If we want to have more collaboration, we'll ask patients for permission if they have the capacity to engage in that. And we always disclose that we're going to report unless we think it's going to put them on an increased risk. There's been very few cases where that happened, but we will disclose that, hey, I'm a mandatory reporter and I'm going to do this because we feel that it's important for the patient and family to know where that's coming from and have a conversation about it, and a conversation about where it's going to go from there. And we will often ask if the patient wants to be part of that reporting, if it's appropriate, so that they know what they're getting. And we have kind of coined the term like trauma-informed reporting, where we don't want to take that power away from the patient. We want them to feel like they know what's being disclosed, they know who's involved, and putting them back in the driver's seat. So that is a big part of our ethos. And then the other piece is just keeping that patient at the center. So we are all, pretty much all of us are geriatricians or geriatric nurse practitioners, and we see advocating for older adults as a core to our specialty, and making sure that their voices are not lost in these really big systems that can often be really overwhelming. So saying, you know, this is what they want. Yes, it's like maybe not the best choice, but this is what they want, and really putting them at the center of our care and making sure that their voices are not. So the first of the big ethical frameworks that we use every day is dignity of risk. And this is a concept that is core to geriatrics, although I don't think it's permeated out into other medical specialties as much. But it's the idea that there's a lot of dignity to being able to make risky decisions as adults, and that older adults are often prevented from having that dignity more than their younger counterparts, that there's an impulse to try to protect them, which I think is very well-meaning, but does cause some ethical issues. And so this case here demonstrates a lot of what we deal with every day. So an 88-year-old woman presented to the hospital multiple times due to abusive interactions with her son. She lived alone with her cats and experienced hoarding disorder, but would intermittently let her son stay with her until the situation escalated into a physically abusive incident. She would go to the hospital, he would leave the home, and then after a period of time, he'd come back and kind of rinse and repeat. This would go on and on and on. Her capacity would wax and wane, but most of the time they did feel like she had capacity to make discharge decisions. And she said, I don't want to go anywhere else. I want to go back home because my cats are the main comfort in my life. And I want to return and to care for them. And if I go to a facility, I can't bring them with me. And this is the life I want to live. This is what I want to do. And so that was honored. And so the team would work with her to try to make that as safe as possible, but understanding that that is a choice that she has the capacity to make, and she gets to make that choice, even though it's, you know, we worry about it, but it's not our choice to make. That is her life, and that's what she gets to do. The other concept that we talk about a lot is this concept of a harm-reduced discharge. And so we are never going to be able to make it a safe discharge. And there is no such thing as like a completely safe discharge. So how do we get it as harm-reduced as possible? How do we work with patients and families to make a not great situation as good as absolutely possible? And so I think this case here is a good example. So we had a 74-year-old man who was found on the side of the road, dehydrated and attempting to defecate on the curb. EMS brought them in. The admitting medical team was doing their history, looking through Care Everywhere, found that he had been at a facility. They did a really thorough history. They called the facility, found out the patient's son had decided to discharge him against medical advice, and the long-term care facility was really worried about that. It's their financial motivation. We're not sure what's going on, but they had already actually made a report. They were so worried. Our team got involved. The patient unfortunately couldn't provide any history due to his cognitive status. He had really developed moderate stage dementia over the past couple of years, and the son didn't quite understand that. But we were able to talk both with the patient's daughter and the son, and they both reported, you know, their father had always enjoyed being outside. He had been unhoused for 20 years ever since his mother passed away. He liked to sleep outside. He liked to be able to walk anywhere he wanted. It wasn't necessarily a financial decision. He just really liked that freedom and liked that level, that lifestyle. So the son reported, like, you know, Dad and I do this together. We live outdoors when the weather is nice, and when it becomes colder, we go and try to find more permanent housing or something that's a little bit safer. And he was actively trying to do that at that time. The daughter lived in Mississippi. And our VESPA team, particularly our social worker, was able to really have a lot of conversations with daughter and son and say, like, we know that this is a core value, but winter is coming. And also, your dad now has dementia. And so things might have to change in terms of how this looks for your family going forward. So we were able to get them down to Mississippi to stay with the daughter for the winter and tried to really provide a lot of dementia education and connect them to resources for further dementia education so they could understand where their father's capacity was at this moment, and what they needed to do to keep him safe, but to honor the things that made him happy over his entire life. So, you know, this discharge was, I think, somewhat uncomfortable for the primary medical team, but was actually a really good outcome for this patient and his family. And notably, we have not been reconsulted on him, so hopefully that means things stuck. The other piece that I think makes people really uncomfortable about our cases, but is ethically quite challenging, but really important, is that we often have to engage the harmer in decision making. So most often, people with dementia who don't have capacity and are being abused, it's by their decision maker because that's the closest person to them. And so we have to often engage that person, even if they're not their legal decision maker, they're most often their caregiver, they know them best. So we need to engage them in that, in a lot of medical decisions and in a lot of caregiving decisions. And our team's motto, again, comes from Henry Kemp. Henry would say abusive parents love their children very much, but not very well, and our task is to help them do it better. And we take the same ethos with abusive family systems. So a lot of times there's a lot of love in this family system, but they don't know how to care for each other, or it's a family system that has interacted via violence for a very long time. And we are going to try to help them do better, and help them take care of each other a little bit better. So this was a good example of a time that we engaged a harmer where we had really high concerns about his ability to care for the patient. But I think we really successfully engaged them. So this was a 77-year-old man who came to the hospital after his neighbors found him outside his home. This was in January. He had known history of dementia, and his brother was his caregiver. When he presented, his core temperature was less than 90 degrees Fahrenheit, so exceptionally cold. While he was here, reports were made. He was rewarmed, moved to the medical floor. APS actually worked really quickly and substantiated ongoing financial exploitation and neglect by his brother while he was in the hospital, and recommended that the brother not be a surrogate decision maker. APS was actually going for emergency guardianship, and the court process had started. However, while that process was going on, the patient started to become more acutely ill. As is common, people with dementia, he suffered from aspiration. And it was really to the point where we were thinking, does this patient need to be intubated or not? And we didn't have a medical decision maker. And intubation's a really big decision for any patient, particularly someone with dementia and end-stage dementia. Aspiration, pneumonia, and pneumonitis is often a way people with dementia pass away. And so intubating them can be a really, really big choice. It's also really hard to get them off the ventilators often. As we didn't have a family member who was able or willing to be a decision maker, we didn't have a guardian yet. The medical team was really just left not knowing what to do, requiring intubation for this patient. So ultimately, the VESPA team, the primary team, and the ethics team got together, and we did what was kind of more of a supportive decision making, where we had the brother who still wanted to be engaged, telling us, these are the core values of my brother. He loves music, he likes to eat, he likes to be able to talk to people. And those are really the things that bring him the most joy. And so we were able to say, okay, like with that core value system, how do we move forward? And so we would allow him to eat and allow him, we didn't intubate him, super urgently. Ultimately, another family member was identified through the court process, actually, who served as his surrogate. And he did end up passing away in our hospital. But I think this was a good example of how we could engage the harmer and saying, okay, you can't be the decision maker, but just tell us about your brother. Tell us about this man that you've loved for a really long time. And what do we need to do to honor him and his life and what matters to him? Then one of the big things that we see on the ethics or on the VESPA team is moral distress. And this is not something I really anticipated when we first started VESPA, but I think it's actually become a core part of our clinical practice. We see cases that cause people a lot of moral distress. People don't want to think these things happen to older adults. They certainly don't want to think it's happening to their patient. When it does, they have a lot of distress about it. There's a lot of times that we don't have a lot of legal options of what we can do to intervene. And so providing that support for staff has become really core to our practice. And one example of a case that caused significant moral distress was an 86-year-old woman. I've changed all of these ages just for de-identification purposes. But she had a known history of dementia. She came to our hospital system, both outpatient and patient ED, several times with multiple bruises that were highly concerning for physical abuse. The husband was her DPOA, and he would repeatedly make comments to staff that he was abusive towards her. He would be joking about abusing her, and then he would decline to provide care and to allow others to provide care that were for her benefit. So she couldn't feed herself consistently, and he would get mad if anyone tried to feed her and would try to impact the care. The only other family member was a son, and he didn't see any problem with his father's behavior. We had a strong suspicion that there was likely a lot of abuse in this relationship, their whole marriage, based on the things he would say and how he would describe himself. The patient did not have capacity to make medical decisions, including changing her MDPOA, and the husband did not make any decisions that clearly put the patient in danger. And so he remained her MDPOA, including discharging her home with him without any additional supports on several occasions. And because she kept coming back in, the staff more level of distress around this case was exceptionally high. And so VESPA tried to provide as much assurance as we could to the medical staff that we were doing everything we could within our legal parameters, and tried to work with the husband and work with others to get her as safe as possible. But we were really limited in what we could do. And so thankfully she did end up passing away in our hospital in a dignified way, and received good palliative care at the end of her life. But this case caused a lot of more distress, and the staff still come up to us and talk to us about this case. And so this has become also a core piece of what the VESPA team does. I will go back to all of the teams, especially with trainees after a patient on VESPA passes away, to discuss the case and discuss the particular distress that comes when we think someone has passed away because of abuse or neglect, or it's been a contributing factor, because that is being different than what we are trained for in medical school. So this is something that we are actively doing. And then some interesting cases that have come up in the last 2 years, really, that we've seen. I'm going to call you as part of using the medical system as part of abuse. And these are kind of evolving concepts. So if anyone has any questions or feedback, I would love to hear them. But one thing that we have seen in particular, and then I'll get to this case, is people getting patients diagnosed with dementia who don't have dementia. And we've seen this now, I think, 8 times on VESPA, and I've also been consulting with law enforcement agencies who have similar cases of this. And this one is really striking to us. So I think this case really was the most egregious form, but I think hopefully we can open up for discussion at the end to talk about this. But we had a 9-year-old woman who was transferred to the U for a complex GI procedure from a rural hospital. Once she got here, she was in the pre-procedural area. The patient reported that her daughter was physically, emotionally, and financially abusing her. On the chart review, the patient had no diagnosis of dementia with a MoCA of 12. However, when we went and saw the patient, she could describe this complex GI procedure exceptionally accurately, had no signs of cognitive impairment. And I even saw her after she had immediately gotten anesthesia, and she asked specifically, did they get the stone in the ERCP? And so she had very clearly no signs of cognitive impairment even after anesthesia. And then when we spent more time with her, the patient reported that she had only attended a few months of kindergarten, but was basically illiterate. So she did not attend school because she grew up in an abusive environment as well. And so she was like, yeah, I can kind of get by, but I really can't read and write that well. And when I went back and reviewed the neurology note, that was never disclosed to the provider. And actually the provider noted that all of the history came from this daughter, and that the patient didn't speak at all during the visit. So ultimately it was determined the patient did not have dementia, and that the reports of abuse were accurate. We were able to corroborate those through other family members and through the local law enforcement. We were able to find a different daughter to help provide support to that patient, and that patient went to a nursing home upon her request. But this was the most egregious case, but we have seen other cases very similar to where when we go back and review the notes, the abuser was present for all of the dementia diagnosis appointments and didn't let the patient speak on their own behalf. And this has changed my clinical practice to now where if I'm giving someone a diagnosis of dementia in my clinic, I always talk to them alone. And I always try to get their independent history, because I'm worried about us contributing to abuse as medical providers, not intentionally, but this is something that's causing us a lot of consternation. The other cases that we've seen recently are manipulation of MDPOA status. So We've seen this now where patients are getting MDPOAs at clinic appointments and they're there for severe dementia and an MDPOA is signed and there's no documentation of whether they had capacity to sign that document in the note. And so we don't know if the MDPOA is really valid or not. We have this case that came into our hospital where a couple in their late 80s were both admitted to the hospital. The wife with altered mental status, the husband with pneumonia. On review of their chart, an MDPOA was completed on My Health Connections 3 months prior and named their granddaughter. When we talked to the patient and the wife about this, they said they haven't talked to their granddaughter in over a year and they didn't even own a computer or a smartphone. And so thankfully the patients actually followed in seniors clinic and their PCP was able to meet with the patient, the primary team and the family, and they had a big meeting and they were able to sort this all out and get the appropriate caregivers going forward. But this one really struck us as concerning where we have, if we do have an abuser who has access to someone's My Health Connection, this is a big problem and something that we're thinking through as a team. We have seen this situation come up now, like only 3 or 4 times in the past 3 years, but it's something that we're very aware of and trying to work through. So those were a lot of heavy cases and a heavy topic, but I do think that overall things are looking up for elder abuse at UC Health. We are seeing more cases, which I think is a sign that we're actually identifying cases, and hopefully that you all who we work with think that we are improving care for these patients and their families. And I think the more we engage in this topic and the more we identify it, the better off we will all be, the patients, their families, and also the providers who care for them every day. So with that, I really appreciate everyone's attention, and I want to open it up for questions. Thank you.
Wonderful. Thank you so much. There are quite a few comments and questions that I will go through from the start. The first is a comment and a question. I appreciate your program started mid-COVID, but do you have any reflections or data on the impact of the pandemic on elder mistreatment? My sense is that the social isolation had many negative impacts more generally on elders.
Yeah, I think that is something, oh, there's so much to unpack there. Yes, in the short word, yes, it had a huge impact. One, we saw isolation in nursing facilities. So a lot of nursing facilities had like no visitors for a long period of time, which was for the safety of the patients, but also contributed to isolation. And we call families out, we had no idea what's been going on in that facility. Similarly with families, usually only one caregiver was seeing mom and dad or any older adults in the system because they wanted to limit exposure, but we know social isolation is a huge risk factor for abuse. We also know like economic stressors, a lot of other things increased in the pandemic. So we do think that there were likely huge impacts. Notably also APS stopped doing home visits for a long period of time during the COVID pandemic, again, for safety, but that I think really impacted people. And so I think this is something that we will continue to see unravel as things go. But that was a big impact for our patients.
Thank you.
Yeah.
A question, did you say that elder abuse is sometimes not reported to the police?
No. Anytime we have concerns for abuse or neglect, caregiver neglect, we report to the police. If we think it's just self-neglect, and I shouldn't say just self-neglect, but self-neglect can be very harmful, but self-neglect is not mandatory reporting. So it doesn't go to police, it goes to APS. But notably, Colorado is the only state where we are mandated reporters to police. Every other state, it's mandated to APS, except for New York, that doesn't have mandatory reporting yet.
Wonderful. There's some conversation about the team.
Yep.
And perhaps you could review the different disciplines, particularly on VESPA teams. The multidisciplinary team involves a variety of people. Wondered if you might be able to repeat that for people.
Yeah, absolutely. So our core team is geriatricians and geriatric trained nurse practitioners. We have a dedicated social worker. And then we also work very closely with our forensic nurses. We also work very closely with the Kemp Center and a child abuse trained emergency physician, Dr. Lindbergh, who's on. And so it's a very multidisciplinary team. And then we will pull in other specialties as needed. So I go down to the radiology reading room like once a week and talk to them about things. And we will pull in the primary team, the burn team, neurosurgery as needed for our evaluations and our conversation.
Wonderful, thank you. Okay, a question about one of your cases. In the case of the 86-year-old woman, was the husband the one bringing her into the hospital for treatment?
Yes, interestingly, yes, it was. Yeah, so she was bringing him, or he was bringing her in, and then would make comments about abusing her. It was a
He would
very
make
interesting
comments
thing.
about abusing her. And what was your interpretation or their interpretation of what he was doing?
So he would make comments such as like, oh, well, if you're gonna admit her to the hospital, it's gonna be harder for me to abuse her. Things like that. So it was pretty flagrant, sorry. And her bruising pattern was also exceptionally concerning for physical abuse. And so we made a lot of reports. APS and law enforcement took it very seriously. But we were limited.
Is APS generally very responsive, quick and efficient at responding?
In a nutshell, no. So APS is a state-funded but county-administered agency. So you will get a very different response depending on which county you call. All APS agencies in the state have 72 hours to review the case and either screen it in or screen it out. And then they have 60 days to make findings. So if it gets screened in, they have up to 60 days to make findings. So some county agencies won't engage with anyone from the healthcare system for 60 days. They will say, I have 60 days to complete my investigation. You can provide information to me, but I won't provide any information to you. Other agencies have interpreted our team and the healthcare providers as a protective service, and so they will engage more with us. It's just quite variable and quite all over the map. But it's also important to remember APS has no police power. So they're not like CPS, you can take children away. APS, if someone doesn't answer the door, if the patient doesn't want them involved, they cannot force it. That is not within their legal purview. So they are much more limited in what they can do than CPS.
Thank you. Okay, what can you say about the ethics of how institutions strip elders who are already vulnerable of their life context and individuality, and then provide them with standardized care or a one-size-fits-all approach to care? It seems like VESPA is trying to individualize care, but it could be at the expense of autonomy.
Yeah, and I don't quite understand the last sentence there, but in terms of institutions, I think, it's always been very interesting that the only institutions that persisted after deinstitutionalization in the 80s are nursing facilities. I think that goes back to a lot of the history of public health. I think some institutions do a much better job of trying to individualize care and individualize what's available to older adults. But our aging care system is vastly lacking and vastly under-resourced. Really, all of aging care was developed in the 1960s when most women stayed home and were the primary caregivers for older adults. So we don't have a lot of good options, is what I would say to that. I think there's a lot more emphasis of trying to keep people in the community, keep people in their homes. We are trying to do that as well, but sometimes that's not an option because of abuse. And usually those are the very egregious cases. We really like to see placement as a worst case scenario and trying to keep them in the community as much as possible. So I hope that answers your question.
Okay. A number of very complimentary comments about your talk. I think it has been very helpful. One person would like to hear you speak on the issue of universal screening at every hospital encounter.
Thank you for that. So the best evidence right now is that we don't have any evidence for universal screening. I have deep concerns about universal screening. It's currently a level I of the USPSTF task force recommendations, and I was part of the AGS group that wrote support for it to remain a level I. We do not have any data that any intervention reduces risk after identifying abuse. And when done poorly, screening, I worry, could increase the risks for patients. So if you ask a patient who's in an abusive relationship, hey, are you being abused in front of their abuser? There's a really high risk that that could escalate violence. And we know that from the domestic violence literature, intimate partner violence literature. And so unless screening is done very well and we have a clear intervention that we're going to put into place, I am very concerned about screening. I really don't want to put our older adults at risk, and I really don't want to put our staff in a bad situation either. And then we are also mandatory reporters. So a failure to report concerns for elder abuse or neglect in the state of Colorado is actually a misdemeanor. So if that provider doesn't report, they're open up to a lot of liability as well. So I think if we want to do universal screening, if that's something that we want to do and we want to engage with, well, it's going to take like a lot of thought and planning to make sure that we are doing good for our patients.
Wonderful. Is reporting of possible abuse anonymous?
It can be. So you can report anonymously. I typically don't, again, because I want that patient to maintain that relationship. I don't want them to think like, hey, I went to the doctor's office and then all of a sudden APS showed up and no one talked to me about that. Like, I think that breaks the relationship a lot more than me saying, I am legally required. This isn't just my license. Like, I could be charged with a misdemeanor if I don't call. Let's have a conversation about what that looks like and go from there. Yeah.
Mm-hmm. You had a slide and a few slides really about MDPOAs and the various scenarios with questions about who's going to make the decision. You had one case in particular where they were applying for guardianship, but and treatment was of essence. So how do you navigate if the MDPOA is even a suspected perpetrator?
So our experience has been, and we've worked with our legal team a lot, Ellie and I talked a lot, is that unless we think they are making a decision right now that puts the patient at imminent risk, they will be maintained as the MDPOA. That is because that patient has appointed that person. And so respecting part of their autonomy is respecting who they trusted to make decisions for them when they could no longer make that decision. And so often they will be the decision maker. We've never had an MDPOA removed as decision maker. And so then it gets to how do we engage them in supported decision making? How do we kind of explore what's been going on? How do we work together and really partner with that person to get the patient the care that they need?
Thank you. So to back to the inquiring, at a practical question about at what point does inquiry begin? Immediate visual observation upon presentation, special teams in the ER, in admission. Would an elderly patient ever be discharged without a formal process that investigated all of this, if there were no reasons to suspect? We can go there in a lot of different ways, but if there were no reasons to suspect elder abuse, or are all patients over a certain age required to have this investigation?
Yeah, no, certainly not all patients. No. So we are only called if there's concerns for abuse or neglect. So it's up to the primary team to say, hey, something seems funny. We do get consults from a lot of ancillary providers, so like physical therapists, occupational therapists, nurses. They can all call us. We always have to get approval through the medical team because we are like physician consult service, but we're only getting engaged when there's concerns. It's not just a writ large thing.
Okay, thank you. One more question, but we are at time. And so everybody, thank you so much for your questions and your comments. Very, very helpful. And Dr. Bloemen, thank you exceptionally well for this presentation and for your work as well. This has been really, really helpful and appreciate it. And thank you, everyone. We hope to see you next month. Again, we're going to be talking about psychiatric ethical issues with psychiatric diagnoses and decision making. So thanks. Bye-bye.